Welcome today to the Healthier Washington webinar series Kickoff. This is the first of our planned quarterly webinars to update you as our interested partners on the work and progress of the state's Healthier Washington initiative. My name is Nathan Johnson. I'm the Chief Policy Officer here at the Washington Healthcare Authority and also privileged to be serving as the Healthier Washington and really do look forward to our continued partnership on this initiative. So just some quick housekeeping for those of you who are listening and watching in this morning. First of all, there's two options for audio. You can use your mic and speakers or you can use the telephone. If you plan or hope to speak, we would ask that you use the telephone for audio quality purposes. There will also be some opportunities to submit comments and questions throughout, both online and verbally, and we'd ask you to be prepared to speak if you'd like to comment during the question and answer period. So there will be time for questions at the end, but questions can also be submitted at any time via chat. Additionally, throughout the webinar, we will pause to answer a question or two that have been submitted via the question pane. So briefly on today's agenda, by the end of the presentation, we hope that attendees should be able to speak as to why Washington State is pursuing this undertaking, to have a good sense of Healthier Washington strategies and key foundational elements, and how to engage throughout the duration of this initiative. By 2019, we will have a Healthier Washington with three main strategies: building healthier communities through a collaborative regional approach, ensuring that healthcare focuses on the whole person, and improving how we pay for and deliver services. We'll also be talking to you in more detail about some engagement opportunities. It's now my privilege to introduce you to some of today's presenters. We have joining with us this morning, first, Dr. Robert Crittenden, or Bob as we call him, the Senior Health Policy Advisor for the Office of the Governor, and who is really visionary leadership for this effort moving forward. John Wiesman, who's joining us today, is the Secretary of Health, serving over the Department of Health and a critical partner in this activity. We also have with us my director, Dorothy Teeter, who heads the Healthcare Authority and who is the executive sponsor of this Healthier Washington initiative and chairing the governance process moving forward. And finally today, I am your facilitator, and I've already introduced myself, so we can certainly move on to the next slide. And here I am turning it over to Bob Crittenden to take it away.
Thank you very much, Nathan, and welcome everybody. This is really the beginning, I think, of a long journey that probably will never end, but one that we think is absolutely important. We're talking about really moving beyond just access to care, which is important, but also having a health system that improves the health of our population and not just medical care alone. This is really about breaking down a lot of our silos. It's about working together collaboratively. It's about focusing on changing the way we pay, so we don't just pay for widgets, but in fact we bend the cost curve. But we only want to do that not by our usual cutting costs and cutting rates, but by actually improving the services we provide, doing the services the right time, and making the qualitative changes that need to be there so we improve the quality of care. It's also about integrating services. We know that people with who are severely mentally ill do in fact die 25 years younger. You know, for us to overlook that and not include them in our health system so they get not only the mental health services but also the physical services that affect their life is our responsibility. We need to stand up to that. We need to have a better system. The current state is, you see on your slide there, is our usual, but it's pretty broken up. It's disjointed in a lot of ways. It's not integrated, and also it doesn't use the technologies and the approaches we know work and can improve the care we have for people. The better system demonstrates how we hope to transform our health system through Healthier Washington. With this initiative, we want to build healthier communities. We want to collaborate with the local, regional groups so that we can best I'll say, integrate the medical care that we pay for through the state with those community groups that actually impact the health of our communities at the local level. This way we can actually improve the health and by using both tools, both the local services with the health services that we pay for. We want to ensure that health focuses on the whole person too. We say that fairly easily. I would sure every doctor, which I am, thinks we take care of everything. But in fact, what we do oftentimes is bypass things like housing, mental health, the different social determinants we need to make sure that people have available for them so they can improve their health status. And finally, we need to really make sure we pay and deliver services that focus on quality and cost, and we need to really make sure we make this a cost-effective system now and into the future. We need to have both, all three things. We need to have better health, better care, lower costs, and we got to move it from just being something we talk about to something we're doing, and I think that's the heavy lift that we're all involved in right now. We also know that if we do this, it's good for the cost of care, and I think it's much more sustainable in the long run. So, what is Healthier Washington? Is predicated on this whole, the three things, the better health, better care, but lower costs. But it can be achieved only if we really work closely with communities throughout the state. This requires actually a lot of change in what we're doing. We have to change not only our delivery systems, our financing systems. We have to really make sure we integrate those social determinants that John can talk about a lot more eloquently than I. And we also, the Healthier Washington proposed a new way of doing business that reaches across our organizational silos. We talk about this as being, this is not just a state government activity. I just want to be very clear, this is us working together with everybody, both providers as well as community people, to put a product, a system together that actually helps the people in our communities. And so we're one player in this. We hope to be catalytic and helpful, but it's all of us that have to pitch in together. So in order to achieve this, we really need to make sure that we have the right systems and the right supports, and that's what we're talking about here. And I'm going to turn it back to Nathan now to let him talk about what that is.
Great. Thank you, Bob. So by 2019, I think we all hope on this call, on this webinar, to have a Healthier Washington. Let's do a little bit deeper dive beneath the strategies into how this is actually going to work and how we're going to leverage our recent receipt of a grant to do so. The plan for a Healthier Washington, as I alluded to earlier, really does fit into three parts. The first is building healthier communities through a collaborative regional approach. We've talked a lot about that in the past and over the last year and a half of innovation planning activity. But we want to leverage, through this grant and through support of other philanthropic and private sources, accountable communities of health that will link and align partners across the care and community continuum. This is what Bob was speaking to. I think it's fairly fundamental across our state agencies, those represented on today's call, that we believe that 80% of overall health at a community and personal level are affected by things that occur outside of the delivery system. So it seems to make sense, given where we put all our resources today on that health delivery system side, that we draw better linkages to those community and other social supports and determinants of health that are actually driving or capable of driving health improvements. This also figures very prominently in agency activities around our health and all policies approach, essentially to ensure that communities are at the table in everything we do, from rulemaking to pursuing legislation to implementing programs. And finally, using data to drive community decisions. One specific asset we hope to stand up over the next 4 years of this grant are health mapping resources, leveraging some of the best approaches and technology to this that exists in the country at our own University of Washington. A Healthier Washington will also have an integrated physical and behavioral health system in Medicaid that is capable of serving the whole person. Today, what we have is fragmentation and silos at every layer of the cake, if you will, whether you're looking at the administration, financing, or delivery of that care. There are some phenomenal exceptions to that across our state, and that's what we want to scale and spread across the state over the next 4 years. Finally, a Healthier Washington intends to shift 80% of healthcare purchasing in Washington state, paying for volume to paying for value. This requires tremendous investment in infrastructure and a fair amount of state leadership. We've coined that under this grant with state as first mover, a recognition that nearly 2 million covered lives we're responsible for here just at the Healthcare Authority alone, not to mention the responsibilities of our partners, the Department of Health and DSHS, which expand even beyond that. Finally, I think a very powerful underpinning for this that sets Washington State apart even from some of its peers that are involved in this testing grant process is the very significant bipartisan legislative support reached in 2014 through governor request legislation, as well as additional resource commitments that go far beyond just this grant. So the implementation tools, what are they? You heard me call out $65 million, a grant that we received in a competitive process. 10 other states received it with us, and we will have that money to spend over 4 years. Worth noting that this dollar amount exceeds anything we would have expected under round 1, and so we feel quite privileged to be a round 2 SIM state in this case. We also had a state budget allocation received as part of the legislative process last year, which allowed us to bridge between grant funding periods from July to 14 through June of this year. Significant investments under that initial funding in some of our performance measure work, as well as standing up 2 pilot accountable communities of health in this state. I've alluded to the significant in-kind and philanthropic support that's been committed and will be leveraged over this period of time, and would also call out House Bill 2572 and Senate Bill 6312 as those 2 pieces of legislation that passed that I think I would call them some of the most significant health policy legislation we have seen in a very long time in the state, and very, very, I think, innovative at their underpinning. Next slide. So we do have a grant budget over 4 years, and I would say, and I think the numbers indicate here, that it is quite front-loaded, remembering that we want to scale this fairly immediately, and we also want it to be sustainable. So as much as we make upfront investments as we go throughout this grant, we want to ensure that our state, as well as public and private partners and agencies involved in this, are ensuring that these efforts are sustainable and not overly reliant on the grant to see them past this 4 years. This is important to us on the planning side and incredibly important to our partners on the Center for Medicare and Medicaid Innovation side. So tied to those 4 years of funding are 4 real phases to this work. Year 1 being some design work. Years 2 to 4 will be testing and rapid cycle improvement of all of these initiatives, meaning in year 2 we officially launch some of the model tests that we've called out for, and we'll go into more detail today. Year 3 will really be a learning and refinement period, leveraging the data and learnings that we've achieved over the first 2 years of the grant. And year 4 will consist of very significant evaluation tasks, both those we funded at a state level, as well as those we will be accountable for from the CMMI side, because they will have an external evaluation of this effort, remembering that they want these tests to prove something at a state level and be applicable to other states and spread and scaled as a result. Very briefly, how does the budget break down? First, by grant area, you'll see there's significant investments across our 5 main investment areas. We'll talk about these investment areas in more detail, so I will not belabor the point on this slide. You'll also see that much of the investments are in external contracts, external consultants, I would say less in the advice column and much more in the actual service and implementation column, especially as it relates to our consultants and contracted services that will be performed under this grant. Next slide. In addition to this all, what we recognize is to achieve the level of transformation, especially the level of transformation called for under the Medicaid book of business through this grant, there are other tools that are available to us, other tools that states have successfully pursued of recent. One such potential tool that is being explored now is how a Section 1115 waiver could fit into this. We've had very preliminary discussions with the Centers for Medicare and Medicaid Services. We believe ultimately that a waiver could give flexibility to accelerate health delivery system transformation, give Washington some additional investment needed to effectively scale, spread, and sustain transformation. We believe it also helped fully capitalize on federal investments, both through the Medicaid expansion, a very significant investment on the federal side, as well as the SIM grant that we've received, as well as strengthening Washington's commitment to community empowerment and accountability. For those of you on this call, we will be having another webinar on this subject shortly on March 10th, and you will see more information on that very shortly. It's now my privilege to transition this presentation over to our Secretary of Health, John Wiesman, who's going to walk us through several of the strategies under this from his perspective. And take it away, John.
Great. Thank you, Nathan, and good morning, everyone. It's great to have you all with us. This has been a journey of many years in the making, not obviously just the last two, so we're thrilled to be at this point and to have you all with us. I understand there are over 400 people who are registered for this call, so again, this is about a huge group of people who are wanting to see transformation in our state, and we appreciate your partnership in doing that. So we're going to talk about these strategies now, and the first strategy, which we mentioned earlier, is about building healthier communities through the regional collaborative. And a big portion of this, as you know, is accountable communities of health. So we see engaged communities as driving local health innovation and partnering with the state on health purchasing. And the foundational element of this is the development of the regionally based voluntary collaboratives, which we call accountable communities of health, or fondly ACHs with all the acronyms everybody uses, and that these are going to drive integrated delivery of health and social services, and ultimately we're looking to improve population health, as Bob talked about earlier, including looking at the social determinants of health that we know affect health and health care in our state. I'll just add that we did these in part by looking at the great work that was happening around the state, where there were already regional groups coming together and saying we need to work out of our silos as we look at health reform. Folks clearly saw that this was going to be important. So we've capitalized on that and are taking that model statewide. So the accountable community of health is indeed an initiative based on the premise that no single sector or organization in a community can create these transformative, lasting changes in health and health care. That we need clinical, community, and government entities to coordinate their efforts and actions around clearly defined goals that support the whole person health. The ACH initiative, as we know, formally recognizes the impact of cross-sector alignment, partnerships, and commitments to improve health and lower costs in communities across Washington state. And as I said earlier, local communities had already recognized that even before we got involved in the SIM work. So we recognize that health and health care are local. As a matter of fact, when I interviewed for this job with the governor, that is actually what I said to him, that this is about local communities where health care is actually delivered and that we need to be supportive of that. So therefore, a collaborative community approach is necessary to achieve Washington's aims of better health, better care, and lower costs. Clinical, community, and government entities must coordinate their efforts and actions around, as I said, these clearly defined goals that support the whole person health. And once designated, accountable communities of health will provide the forum, the organizational support, and state community partnerships to achieve the transformative results through collaboration. Nathan mentioned earlier House Bill 2572, and that's the bill that authorized funding to designate and support the early implementation of this initiative, including funding for 2 pilot accountable communities of health to focus on startup initiatives. You can see on the slide the 2 pilots that were selected, the Cascade Pacific pilot, which has a backbone support organization by Choice Regional Health Network, and then the North Sound Accountable Community of Health, and their backbone support being the Whatcom Alliance for Health Advancement. These pilot grants began in January of 2015 and will conclude in June of this year. The pilot ACHs will be the first to test the ACH construct and will create a unique opportunity for the state to evaluate and share lessons learned to inform the future ACH development. And we'll be talking about these as how they are aligned with the regional services for Medicaid purchasing in a little bit. So we believe Washington is unique among other innovative community health collaborative models in its expectation to partner with empowered and accountable communities, not as risk-bearing entities, but as true partners with the state and regional purchasing to better align sectors, resources, and strategies around community and state priorities. So this is really getting the best of both local and statewide approaches. So we're well into the ACH design and implementation, but we are early in the 4-year process in terms of this grant. We still have a lot to learn in partnership with our community partners, and that is intentionally built into this process, both with the bill that authorized these early pilots and this work. So at this point, I'm going to look to see if we have time for questions, or do we have any questions that have come in on the chat? Okay, we're going to keep moving along. So looking at the second strategy, as we mentioned, is ensuring healthcare focuses on the whole person, not just the head or the body separately, but both together. We're really going to talk about health and addressing things like 25 years of less life expectancy. In some populations, we need to do this work. So Healthier Washington will have this integrated physical and behavioral health services in Medicaid that serve the whole person. The current system, as we know, creates barriers to addressing physical health, mental health, and chemical dependency and basic living needs as early as possible and at the same time. Healthier Washington calls for methods of integrating care and connecting with community services to achieve the best possible result for individuals. And obviously, as we do that for individuals, we then do that for the population as well. It also adjusts how we pay for services to make care for the whole person possible, both mental health and substance abuse. The governor's vision, the historic legislation we have, and the plan upon which the Healthier Washington is built provided the critical underpinnings of a transition towards a fully integrated managed care system that provides physical health and behavioral health being both mental health and substance abuse disorders, services on a statewide basis by January 1st of 2020. So achieving the goal of integrated purchasing and delivering will depend on effectively coordinating the healthcare delivery system with community services, social services, and public health. To support these linkages and increase the local accountability for better health, better care, and lower costs, DSHS and the Healthcare Authority, HCA, defined in November 2014 some common regional service areas through which Medicaid and state-funded physical and behavioral health care services will be purchased beginning in 2016. These regional service areas will drive the accountability for health and outcomes by defining the structure for health and community linkages. They will comprise the new service areas for Medicaid purchasing of physical and behavioral health care and serve as a foundational component of the aligned state agencies' health and all policies approach. The map on this slide provides the geographic regional service area boundary designations, which were determined based on guidance from the legislature's Adult Behavioral Health Systems Task Force and significant stakeholder input, which I'm sure many of you on the phone were engaged in. One note about this slide, if you look to the northeast corner of our state, the North Central and Spokane regional support areas constitute one combined behavioral health organization. So with this, we've got the single behavioral health organization serving both of those RSAs. The Apple Health Managed Care piece, New North Central RSA, is separate from Spokane RSA when we look at the Apple Health Managed Care. So the legislature set forth two tracks, I think as many of you know, to integrate purchasing by 2020. One is known as the early adopter, and the second the behavioral health organization track, that first one. The early adopter regions will have physical and behavioral health services purchased on a fully integrated basis by April of 2016. And other regions then will begin this transition by having care delivered through separate but coordinated behavioral health and physical health managed care contracts. The two key integration strategies aligning towards the effective system transformation include, as we've discussed, the state's purchasing approach to support the integrated physical and behavioral health care with links to these community resources. And the other is the development and spread of sustainable and effective models of integrated physical and behavioral health care. Now, along with all of this work, supporting practice transformation is going to be critical. So the Practice Transformation Support Hub will support providers across the state to effectively coordinate care, to increase capacity, and to benefit from the value-based reimbursement strategies that you'll hear about from Dorothy in a few minutes. Now, specifically, the hub will do 3 things. It will provide technical assistance and practice facilitation around co-located or virtual team-based bi-directional care, this integration of behavioral health and primary care. It'll support the uptake of evidence-based initiatives that improve quality and value. And it will provide focused technical assistance to improve person-centered care planning and management across the broader care team, including supportive housing, supported employment, school-based nursing, and long-term services and supports, that linkage to the social determinants of health. The hub design will have the Department of Health convening stakeholders this year during the design year to provide input into priorities, design, and function of the hub with an aim to build upon the practice transformation support efforts already in place statewide. Now, foundational to the practice transformation support statewide is a high level of patient engagement and a flexible, expanded workforce. We know that during the development of all of this that there was a great deal of interest in this. There are many folks right now across sectors who are providing some of this transformation work. We're excited to engage with folks on that, to build upon it in our role of leading this at the department. So rest assured that this design phase is going to include you all in thinking about how we move forward and building upon what's already there and using technical and trusted professionals in the field already. And with that, I'm going to we have a couple of questions.
We do. So we're getting a few questions about the alignment between the regional service areas and the accountable community of health boundaries and how those are complementary of one another.
Great. This is Nathan. I'll address that question, and then I think John might or Dorothy might have some things to add to it. From early on in the process, we were trying to engage the regional discussion with as much flexibility as possible. Worth noting that the community of health planning regions were formed at a grassroots level and were identified by community members themselves as fitting regions. What that turned into is those initial discussions had some impact on the regional service areas for purposes of purchasing. And naturally, where we've landed is a desire, at least on the state agency side, to have as much alignment as possible between the two. So that is to say, at the present, all of the ACH pilot communities, as well as those moving forward in a design and planning phase, have alignment with the regional purchasing areas that, not just alignment, but it's identical in nature. We think that's very positive, especially for the role we hope to see the community playing in purchasing efforts going forward. I know that John or Dorothy might have some things to add with regard to regional alignment.
Just from my perspective, I think, again, this is key to getting systems to work together and focused on common outcomes that we can share and hold each other accountable to. So we think this is critical, and we look forward to everybody's engagement in working cross sectors, both on thinking about what it is we're purchasing, the outcomes we expect for that, and how the community, whether it's the social service community, public health, healthcare delivery, come together on common shared goals to actually move health across the state and reduce costs while we're doing that. Great.
So we're also getting a few questions asking. Oh.
Go ahead, Dorothy.
Oh, yeah, I was just going to add one thing, which is this structure also, if we step back a bit, will really allow us to understand what's working and what isn't from a fairly stable platform. So we know what those geographic boundaries are. We know what the community assets and the healthcare systems and the data is within each one, so that as we're going forward, we can have a very systematic way of sharing what we're learning and what's working and what isn't. So I think this is a really important piece of infrastructure for the state to use as a really solid platform going forward if we're going to transform the health system across the state.
And I think I would just add it supports the innovation and the fact that innovation occurs locally and that folks have different ideas and different needs. And so our ability to learn from that is going to be really exciting.
We're also getting a few questions just asking for further clarification on the envisioned role for accountable communities of health in purchasing, how that will interact with the county's role, and also how some safeguards will be in place around conflict of interest.
Great. This is Nathan. Let me first tackle that, and then I might turn it to Dorothy too for any additional comments. I think one thing that is worth saying here is we are exploring new territory. You have a very strong commitment, especially from the 3 lead health agencies that are part of this process, to start engaging communities in a new and very meaningful way. And so one of the absolute things we're intent on working on is how that engagement can be very substantive in our approach, first to Medicaid purchasing, but of course we believe ACHs will be ultimately affecting much more than just Medicaid purchasing going forward. But in the Medicaid book of business, there are 2 critical pieces here. One is how a broader multi-sector accountable community of health engages with the health agencies of the state to move contracts forward, to move procurement forward, and ensure we have a good feedback and monitoring system in place that does better than just a complaint-driven process, much like what we have today. So I have a lot of hope in a process that will be moving forward and that will really be testing with some early adopter integration moving forward. And I think Dorothy may speak more to that in just a bit here. I guess the other piece I would say is counties have a very unique role today in Medicaid purchasing that isn't taken away by any stretch with the involvement of accountable communities of health. And so one thing, even as we pivot to broader multi-sector engagement in this space, is to ensure that the counties who today have ownership for the most part on the governance fashion of the regional support networks for purposes of mental health services, as well as a fair share of the substance abuse disorder services that are provided to a community, that they have that unique role and unique function that's preserved going forward, as well as the input of the broader community at the same time. To be honest with you, we're still working on the details of how that will work, including maintaining existing conflict of interest provisions that ensure that we are maintaining as level a playing field as possible with any contracting process going forward. But what we're not going to allow is the old way of doing business interfering with a new and I think much more innovative community-led way of doing business, and that's what we are very intent on partnering with accountable communities of health, especially on figuring out just over the next several months. Dorothy, would you add anything to that?
Yeah, the one thing I would add, and it broadens Nathan's comments out to beyond Medicaid, which is I have been out and about a lot recently with some of our healthcare providers, whether they're small groups or large systems, and they're making a very rapid connection between the contracting that the state, for example, does with our commercial book of business with our public employees, where we're going to be requiring achievement of the 3-part aim, triple aim there, which includes population health, and a very rapid connection to both the accountable communities of health saying, oh, we're going to have to really learn how to partner because we cannot achieve the population health piece by ourselves. And they're also making a connection to the transformation hub itself that John earlier described. So as Nathan just pointed out, this is a work in progress, but I can tell you that the healthcare system is rapidly making the connection to the community-based approaches that we've been talking about here, and knowing that we absolutely need that partnership going forward.
Great. Thanks, Dorothy. I think we might have one more question.
We've received a lot of questions around the Practice Transformation Support Hub and specifically what it will attempt to achieve. One specific question is around the support of the uptake of evidence-based initiatives. What might that include, particularly recognizing that we have a lot to build upon, like the BRE Collaborative and other partners in our state?
I think that's a great question, and indeed the whole point of this is to build upon these collaboratives, and that is indeed what the design period is going to be doing, is engaging all of those folks who are doing this work and asking essentially, how do we keep advancing this and build on and actually make this more of a system rather than a bunch of people doing independent work? And how do we then systematically, I think, transfer those learnings and knowledge from the collaboratives, from the guidelines that are being put out, and actually get that integrated into care. And so this is going to be helping with that transformation. But really, if you think about it as a provider level, the supports that they need to be able to make that happen, the tools that they need to have to be able to integrate that into practice, and manage populations within their panel of patients. So this is also about helping providers make sure that they're able to figure out how do you actually implement these in a clinical practice, a very busy clinical practice, what support systems are needed, have the tools that we can commonly develop and share so that everybody's not sort of recreating the wheel. A big part of this will be looking at the integration of behavioral and primary health care. How does that happen? That's going to be, I think a big challenge. Lots of folks are concerned about it, but again, there are those who have been doing this. There have been those innovative projects, and we want to transfer those learnings into practice. So lots more of opportunity for input on this as we move into the design phase. We are really open to the thinking of what people in the field who are already doing this work think will work best and how we connect up with that work.
I think we're going to pivot here to Dorothy to walk us through a little bit further on strategy 3, improving how we pay for services. And Dorothy, if you'd like to take it away from here.
Okay, thanks very much, Nathan. So I guess one thing I would say is, and it perhaps is stating the obvious, but the reason you improve the way you pay for services is so that at the end of the day you can improve the way healthcare is delivered. And so what we really want to understand here is how do we move from the way we pay now, which I think it's pretty uniformly accepted that a fee-for-service payment mechanism for healthcare services is probably not going to get us to the triple aim that we want of better care, lower costs, and improved population health. So the reason that this is so important is that the way that things are funded, as we all know, is what directs us to the outcomes we're after. So that the 4 redesign models that are included in the in our innovation plan, I'm going to spend a little bit of time on each of these, but I think if you want a lot more technical detail, we may want to go offline because it's a lot of information about each of these. But what we're trying to do with these designs, and I want to reinforce what Nathan said earlier, that one of the key reasons that CMS chose Washington State for this innovation grant is that they're actually contracting with us to do a really good job testing different models that then they can use to inform their policies and their purchasing policies going forward. So you already have seen CMS saying they're moving as rapidly as we are, if not more rapidly, away from fee-for-service. So the 4 models, model test 1 is what we're calling the early adopter of Medicaid integration. I'm not going to spend as much time on this one because I think John just described this earlier. But by 2020, again, we want to have fully integrated care delivery and financing of physical and behavioral health services so that a person doesn't get harmed, really, by the current way that we've got our silos of administration, financing, and organization of care delivery. This is not a tall order, but I think, again, people have come to the realization, and including with our governor's leadership, that we need to move forward. Those counties that are choosing an early adopter approach, which will be funding, would be receiving 10% of the savings from the state that result from the integration of these models. So that over the full course of this, we'll be able to understand what those savings are and concurrently what the challenges are for care delivery teams and also what those savings end up being for us. The second model, which we're calling moving from encounter-based to value-based, although I would say that almost all of these are doing this, this is a really focused strategy. Right now we've got about 41% of our current Medicaid beneficiaries, or 1 in 10 Washingtonians, are served in a federally qualified health center or rural health clinic for primary care. Most of rural Washington, as most of you already know, are served by federally designated critical access hospitals. I can say, from my experience in the last couple of years going out and learning more about the rural part of the state, that the providers of these services offer the most innovative, some of the most innovative and integrated delivery models in the state, and yet the way we pay, again, stifles the care delivery innovation that they can imagine. In these settings, are especially difficult with some of the statutory and regulatory barriers that rely on encounter-driven cost-based reimbursement. So with the strong support from our clinics and hospitals that I just mentioned, the state's going to introduce a value-based alternative payment methodology in Medicaid for federally qualified health centers and rural health centers to pursue a new flexibility in delivery and financial incentives for the critical access hospitals that participate. This is a huge opportunity for our state. I know the federal government's really looking to this to see how they can use what we're learning to change even at the national level. So I think that there we've got already people knowing that email, telemedicine, group visits, expanded care teams are not only they're necessary to deliver care across our state, and we want to be able to test the models for payment that will match the care delivery goals that they already are seeing. Model Test 3 is Puget Sound Public Employee Benefits area. The 5 counties, we're going to start there with where we purchase for public employees, although it rapidly moves statewide. We're going to work with our existing partners with Group Health and Regions Blue Shield to test some new accountable delivery and payment models. We have, starting in 2016, we're going to be testing this with a new benefit design and an accountable care network approach and payment that, again, moves us away from fee-for-service. Some of you may have seen that we did a request for information earlier last year to understand kind of where the health systems are in terms of moving from volume to value, and we've matched that information we got with some 3-year, 4-year strategy now with our public employee benefits to see if we can move more of our public employees and their families from a fee-for-service PPO system into more accountable care organization models. So work is already underway with that. Our hope there, and again, the interest of CMS is that other purchasers and union trust members will join us in that effort as we move forward. And lastly, what we're calling the Greater Washington Multi-Payer Model Test, where we're going to drive total cost of care approaches with identified payers, providers, and other purchasers through a statewide high-value network which has a common infrastructure that can integrate finance and delivery. We're ultimately hoping statewide that we'll be joined by other commercial and Medicare payers so we can engage up to 200,000 beneficiaries by 2018. This is a very unique opportunity, and again, I just have to say that the state, some of our big systems and insurance plans are building the infrastructure to be able to deliver care in this way. So more to come on this, but I will tell you that the health systems themselves are moving rapidly. They're organizing differently to move into a pay-for-value approach, which is pretty awesome. And the state, in this sense, is the first mover to help lead the way within that. So next slide. It goes without saying, but I'll say it anyway. None of this can happen without some key foundational elements and building blocks to make sure that what we're doing is not only systematic, but it's also reliable into the future. So the first one of these slides, of these building blocks, is measurement and transparency, if we can have that slide. We had transparency, to me, is the great liberator. We can, once we get more data, more information, we all see it. It's a way faster and more trustworthy way of improving services and transforming. To that end, we're working towards the collection and reporting on resource use, quality, and cost data. Hoping we can get some price data with our current legislative session to drive system-wide improvement in quality and care and cost performance. And I would say also in improved health. This statewide mechanism to collect and report on quality and price data, really we see again with this theme that you're hearing today about moving things out to the community should empower our communities, our patients, and our families to be more educated consumers, to really push our providing system for continuous improvement, to demand different healthcare plans and models so that they they learn what they want in their health system itself. So we're waiting to see there is an all-payer claims database already legislated. We're hoping there are improvements in that in this session that will be even more broad-based than it is. But we're really looking forward to having that functionality in the state. The other thing that the legislature asked us to do was to come up with a core performance measure set. I'm hoping all of you or most of you have access to that. We did spread the word widely on what that final set is. I'll briefly touch on it here. But it's an awesome a step forward for the state. You hear to move forward with our with a common set of measures that increases the simplicity of what we're measuring, so we can all look at the same thing and to move forward with that. So in the next slide, I think the core measures are here. I'm not going to touch on too much on this, except to say it's a huge amount of work we did this year with a statewide group of experts. We considered 27 high priority topic areas, and these are the final draft set of 53 recommended measures. Obviously, these also go ahead along with some Medicaid-specific measures that were also approved a year before, so we'll be working together to make sure that those measures are all integrated. But this is, I will tell you from both the feedback we're getting from both health plans and from care systems, as well as some of our public health partners, is to have these core sets that we're all working on are going to help us with our accountable communities of health. Rapidly then, I want to make sure we've got time for questions. Data-driven decision-making, again, this goes along with the theme you heard from John and Nathan and Bob earlier about using evidence and data to inform what we do. We are going to be working to accelerate interoperability of clinical data, as well as the APCD that has claims information in it. And very importantly, and you saw this in Nathan's earlier slide, we're going to be creating a dedicated team that can analyze, research, and help us measure what's going on, so that we build that more core infrastructure so we can, again, share that infrastructure statewide and learn and adjust as we go. And then lastly, we don't want to ever forget the importance of individuals and families in their care. Again, pushing all of this out as far as we can, out into the communities and into our families is really important. We've recognized legislation in 2007 and in 2012 about shared decision-making and engaging consumers. This will be part, again, of what we work with our delivery systems and use the Transformation Hub to help figure out how to empower our care teams with their patients to have patients' values and preferences incorporated into treatment choices as it makes sense. So we'll be deploying our first decision aids in this area in 2016. And then lastly, and probably from my perspective almost more important than anything, is this continuous rapid cycle evaluation. We will be working rapidly with all of you to learn, adjust, and improve in real time. And we also will have a more formal evaluation led by the University of Washington, aided and abetted by a formal national evaluation team that CMS will provide for us. So with that, I think I'll end with the last slide here. Again, this is just so you all see how we're organizing. This is what we fondly call our layer cake diagram, although it looks like a kind of hideous cake to me for the flavors. This just shows you on the left how we're organizing internally. What's important really for everyone here are those project teams are statewide, lots of people on them. And then to the right is how we're engaging with the community on all of this. I don't want to leave without talking about the Health Innovation Leadership Network. This is something we're putting together right now. The governor will be selecting members for that team, but the focus there is acceleration, leadership to accelerate what we're doing. So that's going to be a really exciting piece of this as well. We should have that formalized in the next couple of weeks. So we have 4 years. I want to just end on the, maybe we can move forward a slide. this is to this. The regular updates we promised we'll do. I want to just end on these are just feedback networks, but this is what I wanted to end with, because what we cannot forget is, and I know every one of us has said this in the presentation, this is a heavy lift, but it's a lift that feels, from what my perspective is very productive. It's time to stop kind of admiring all our issues and have now the ability, with some funding and with the incredible statewide support and stakeholdering that's been done so far and will continue to be turned into participation, to move the needle on this. And I think we're in it for the long haul. We're not going to backslide. We won't. We'll be asking all of you to move with us, and very much look forward to seeing what, at the end of this, what we can get to. As Bob pointed out, it's not just a 4-year lift, but these 4 years will be, I think, incredibly important to us to really make that huge difference in Washington State, so we get to a healthier Washington. Okay, so I'm going to turn it over. I know I talked a little bit too long, Nathan.
You're fine. Not to worry one bit. We've had questions coming in over the course of the whole webinar here, and so we might turn to a few of those, and then I'm not sure if we'll try to get people on the line as well, but I'll look to my colleagues to help direct traffic on the questions.
So while we're waiting for people to raise their hands, we've gotten several questions about the savings component underneath this. And when we're looking at the nearly $1 billion in savings that was estimated by our third-party analysis, is that for state-only savings, or is that across all payers and purchasers? And also, how will the state and other purchasers capture this savings?
Sure. This is Nathan. I can speak to that. A requirement in our CMMI grant application was to provide a return on investment analysis, so we contracted with an independent third party in Mercer to do that for us. And they took a more global view and global lens to the question across, as Laura alluded to, all payers, all purchasers, inclusive of Medicare, Medicaid, state purchasing, private sector purchasing, to suggest if we meaningfully integrated, for instance, services, and given what the literature suggests about the effect of that across all payers, starting with Medicaid, if we achieved legitimate price and quality transparency, again, across all payers with access for consumers and purchasers to that information. In essence, if we lifted off the entire innovation plan and executed it to its fullest potential, what savings against what would otherwise be significant trend in healthcare spending would occur. So in terms of how it will be captured, my suggestion to you is it will be captured in terms of both the state-led evaluation, again, led by the University of Washington, as Dorothy mentioned, as well as our external evaluation. CMMI will be interested in putting their own, if you will, actuarial lens on where our trends were pre-implementation of the Healthier Washington Initiative and where they landed in the future. In terms of capturing the savings, I won't say other than our own independent purchasing efforts on the state side, on the other public purchasing side, and in the private sector, other than their own activities to attempt to capture and reinvest savings. Nothing's envisioned in terms of a structure that would, if you will, capture savings as part of the Healthier Washington Initiative. So this is a conceptual framework and one that will be evaluated as we go through this initiative to see what gains are made and what savings or reductions in trend are achieved.
Great. So questions on health equity. How is this a key component, and how is it being reinforced and emphasized throughout the Healthier Washington Initiative?
I'm very, very appreciative of that question. I think John may have touched on the subject as well. But when we think of some of the data elements and the combination of siloed data sources between even just the state agencies that are involved, but as well our community and private sector partners. But when you talk about the type of data and the infrastructure that will be used in this grant to visualize that data, we believe there's going to be a much better window into various inequities that exist at a regional and population and demographic level basis. And we will be able to better target interventions, again, at a community level as appropriate. So what we've done great work in pockets. King County Public Health, for instance, has led some amazing work in this way. And we want to learn from the best. We want to learn from the work of IHME at UW. We want to learn from King County and other local sources of innovation in this area get very clear on where the problems are, where the inequity exists, so that our approaches, our interventions are aimed where they can achieve the most gain for the most people. And John and Dorothy might have additional thoughts on that subject.
Yeah, thanks, Nathan. I would just add that I think we've got a real opportunity in these accountable communities for health for us to take a look at these local inequities. You know, we've got a lot to build upon. Hospitals and local public health departments have been doing community health assessments and health improvement plans, which we know are addressing equity issues in those. They're being identified and they're coming up with strategies to address those. And I think this cross-system and sector work that will happen in the ACHs is a place where this is really going to happen. And if you look at the inequities that Bob talked about, just in terms of behavioral health folks who live, 25 years less long, that's a huge inequity that we've got an opportunity through all of this system redesign to address. So I think we'll be looking to those innovative approaches in the regional collaborative as part of addressing these inequities, and the mapping tools and other things that will be provided through this grant, I think will help people also be able to visually see those and to be able to describe those in ways that mobilizes, I think, interest in action by not just people who are working in these collaboratives, but the policies. And again, when we get to health in all policies approach for local county councils and governments and city governments to actually think about how their policies drive health, that we've got an opportunity to influence that. Certainly that's been happening already through local health departments and collaborations and other sort of consumer-oriented groups who have been raising these issues. So it's an opportunity, I think, to keep building upon what's out there.
Several questions around how we are broadly engaging stakeholders in the Healthier Washington initiative, as well as our other partners that are critical to this work, specific mechanisms, as well as specifics around engagement for specific partners like our tribe.
I can address some of that. I hope what you've heard messages throughout this presentation, whether the discussion of the Health Innovation Leadership Network, the discussion of accountable communities of health, as well as the multiple ways of providing feedback into the project and hearing about the project and its status. Folks understand we intend this to be an incredibly transparent and engaging process, and one that relies very heavily on the feedbacks and partnerships with the entities that Laura just named. One of the things we saw as particular funding on this grant is some additional capacity in providing more real-time updates, both virtual and updates of this nature in webinar and other forms, to keep people fully apprised and engaged to the degree possible. One thing we want to gauge throughout this and want your candid feedback on is when that is not happening, or when folks feel a particular part of this process is not as engaging or transparent as it could be. We aim very high in this regard. I think I can speak for all 3 of the governance agencies and the 12 state and independently elected offices that have guided this innovation plan work to date. We want people to know what's going on, and we want you to have meaningful input and feedback into the process. So one of the things, the concluding slides that we'll leave you with, is access to our website, which does have some fairly good material and substantive material on various topics that we've hit on today. And that resource is only going to grow over time as we get effectively staffed up and resourced for this effort under the grant. John, Dorothy, would you add anything to that?
I would just say, again, we're committed to this, and from all levels of this agencies, and as we begin processes for input, making sure that that happens. I also just want to point out the Health Innovation Leadership Network and the folks who are on there, and specific to tribes, for example, there are multiple positions that will be appointed to that by the governor, and so really trying to make sure we're paying attention to this at every level. And again, as Nathan says, if you feel like we're missing the boat on something, please let us know early. Let us know before you're overly frustrated so that we can be as responsive as we can.
Final question. There were a lot of there was a lot of information about what we're funding under the Healthier Washington SIM grant today. However, Healthier Washington is more than just the grant, as Nathan alluded to. A little bit more information, Nathan and others, on where people can find more about the exploration of the waiver.
Sure. Specifically, we'll be sending out an announcement today on that subject. We'll, at a very introductory level, be introducing some more educational components related to what waivers have helped with other states achieving the Medicaid transformation, and giving people a window into our very preliminary discussions with CMS on that topic. So be looking for that today. And as I alluded to briefly, the date for that webinar is March 10th. So more information coming and more ways of being engaged through that webinar that we'll provide at the time. Just in closing here, we've provided an email address for ways of getting onto the feedback network. We already have, I think, 1,100 strong of you, and we'd love to keep even more of you informed on the every aspect of this process. We also try not to inundate mailboxes, you'll be happy to hear. So we try to provide the most meaningful of updates, but do so as frequently as we can. So please, if you have any interest and are not already receiving regular communications from us, shoot us a quick email and you'll be signed up. And again, the website is listed there for you, hca.wa.gov/HW. In just closing here, I would like to thank everyone for your participation. We, of course, had a lot of questions from you, and many of which we didn't get to, but many of which will inform our future communications and the next webinar. I am very appreciative of the very broad participation we had in this initial one, and I expect it will only grow over time. So thanks again, everybody, for hopping on, and we'll be in touch shortly on future opportunities. Thanks so much.